You can have a tachycardia or palpitations. The patient feels they have palpitations, a racing heart. Once you know the definition of it, then the symptoms make sense. So the patients come to you with shortness of breath. Now you're considering the possibility of pulmonary hypertension. And the next thing you start thinking, well, what would be the cause of it? Remember I told you that the lungs are being strangulated and the blood pressure starts going up and the right side of the heart starts to what? Pump a little harder to get the blood into the lungs, into arteries that are getting tight. What happens to the the right heart muscle at the beginning? It gets a little thicker. Like when those of us who want to look like Arnold Schwarzenegger, we start exercising, we want our muscles big. That's what happens to the right ventricular muscle. And if you look at a model, it's actually quite thin. But at the beginning of pulmonary hypertension, it gets thick. It tries to adjust, it tries to accommodate for the resistance that it's feeling. Can it do it forever? No. Eventually you get right heart failure, cor pulmonale. And that's where the old term cor pulmonale comes from. It's right heart failure. But it's so ingrained in us, and we've seen so much of this right heart failure that people who've seen it, they just call it cor heart pulmonale, lung failure, because of high blood pressure in the lungs. Okay? And then what happens when it starts failing is it starts pushing fluid up into the right atrium, right? Causing TR, tricuspid regurgitation. And then it starts backing up down the inferior vena cava and the superior vena cava. That's why sometimes you'll see engorged neck veins. And that's why sometimes you'll start to feel maybe a little bit of a liver, 3-finger, 4-finger breath below the right costal margin. Suddenly you'll see ankle edema, leg edema, ascites. So it makes sense. It starts here in the alveoli interstitium, backs up into the right ventricle, backs into TR, into the right atrium, and into the body. Okay? Any questions? Now, the cause in a young woman usually is idiopathic. And there's a group of young women who have a genetic predisposition to idiopathic pulmonary hypertension. And I'll just use, for argument's sake, 40 to 45, someone who's younger than 50, 45, or 50, anybody in the younger age group will have some sort of genetic predisposition to idiopathic pulmonary hypertension. This stuff. So they have some sort of genetic marker that suddenly makes the endothelium within the parenchyma of the lung to start closing down those arteries, which drives the blood pressure up. You will see in the article that you're about to receive from Texas Heart Institute one of those particular genes. The vast majority of everybody older than 40, 45 would be secondary pulmonary hypertension. So you have idiopathic in the young women, 60, 70%. By the way, why aren't the men in there? Yeah, why aren't the men? We die. We don't live long enough. The mortality rate is so high in men that the registries can't put them in there. So if you look at the French, if you look at the Scottish data, the REVEAL study, all of that shows that it's 60, 65, way up there for women. It's better than a coin toss. So women are most predisposed to this. In terms of secondary causes, blood clots in the lung. And it makes sense. If a blood clot gets into an artery in the lung tissue, it'll back it up and blood pressure will obviously go up. If you have a lot of clots in both lungs, the blood pressure even goes higher. If you become short of breath, cyanotic, hypoxic. The other causes would also include COPD. Remember I mentioned that a few minutes ago? COPD. Another cause would be scleroderma or lupus, malar rash. You have to be aware the shortness of breath isn't just from COPD. You got to remember sometimes you have connective tissue disease that causes obstruction from the arterioles of the parenchyma of the lungs. And then you have other causes such as sleep apnea, congenital heart disease, I'll get into that a little bit later, sickle cell disease, chronic liver failure, cirrhosis, AIDS. We also have pulmonary fibrosis, which in the coming years is going to be more prevalent as our population continues to age and live longer. Left heart failure can also be a cause, secondary cause of pulmonary hypertension. Living in high altitudes or moving to high altitudes can be devastating for a patient with pulmonary hypertension. These people who climb Mount Everest, the issue isn't the climb. I mean, we can all get on a mountain and just climb right up. You got to acclimatize. So when they go to these base camps, they're there for days, weeks, to get their body ready for that last ascent. And by the way, in case you don't know, they start like at 3 o'clock in the morning for the ascent. So that way they're up there about 12 and they can get down to that last base camp on the way to the 6 or 7 that night. And that one particular trek got started a little late, like 6, 7 o'clock. It was doomed to failure immediately. It was one of the worst climbs. Certain stimulants like cocaine are very, very predisposed to this problem. Anybody remember Len Bias, that great basketball player from Maryland? That was his problem. He took too much cocaine, got an obstruction, and there you have it. And then here comes my favorite, Eisenmenger syndrome. Remember I told you this will be your basis from which you can learn other things? Eisenmenger syndrome was a particular topic I was asked to speak about there at the Texas Heart Institute. And the guy that I was going to introduce, Dr. Masson, right after me, had a lot of experience with congenital heart disease. Back in those days, adults and pediatric cardiologists worked together. We had rounds just like all of us are right here. That's the way we all talk every morning around 6:30 in the morning about the cases we had. And I was so intimidated by Dr. Masson, him following me, that I wanted to make sure that I got through all the information on Eisenmenger syndrome. So I was so nervous, I was talking about 100 words a minute. You know that little thing at the end of these little commercials you get, where it says, well, that's the way I probably sounded, because I was so nervous and so forth. I think I gave the whole presentation in Eisenmenger syndrome, which is a fairly long talk, in about 10-15 minutes. Then we had the rest of the hour to talk, and meanwhile Dr. Masson's going, well, now what am I supposed to say? So we have 40 minutes to kill. So that was, I'll never forget Eisenmenger syndrome. But basically what happened